Hey guys, hope you guys are doing good. Welcome, Charlene family, to our weekly Hospice 101 lives. If this is the first time you're tuning in, welcome. Welcome to the family. These weekly lives are really just meant to be educational and easy to digest when we're talking about hospice, which is a very scary word. And so, what we've seen over the years is that the education on hospice is not easy to digest and sometimes can be hard, especially when you're in it and you're trying to make a decision. So the goal of these is to really make it very simple, giving you specific facts, but then also we're going to give you a story, a real story retold. So one of our patients, and we flip the script and for HIPAA purposes, and so that way you can step into their life and understand their story and see if that story is a story that you can relate to. We walk through their story, and then at the end, we give a hospice 101 as if I'm giving that hospice 101 to the family for them to make an informed decision. So you get to be a part of this journey weekly with us, and I hope it's been valuable and helpful for you. If you haven't, please make sure you like and subscribe. Share these with so many people that you think may need it, or even yourself. Even if you don't think you need hospice for a loved one, or you're not even, it's just good to know. It's just good to understand the system, at least the very basics, so that you can help someone and guide them through maybe a good decision. So, all right, so let's get started. Facts. Everyone loves facts. You all know facts nowadays can be pulled through ChatGPT. So this is some ChatGPT facts for you. 1.8 million people, closely, roughly about 2 million people, receive hospice care each year. Now, the most important thing about that is not the fact that people are on hospice, but they're not utilizing it. So about 50% actually utilize the full benefit. The full benefit is 6 months or less, sometimes more. And a lot of times it is more as long as your loved one qualifies. But on average, if you see in there, it's 18 to 21 days. So that's not the full benefit that families should be receiving. We hear this a lot, that families will say, I wish I would have known about hospice sooner, or I wish I would have been educated or started sooner if I would have known that I got all this help from mom or for dad. And so that's one of the main reasons why we're doing this, is to kind of educate and help you or your loved one or family member just understand what hospice is. So we are going to talk about Miss Linda. This is real stories retold. Miss Linda Davis. And so Miss Linda Davis, she's a country girl. She's from Kansas, married her sweetheart. And so we're gonna walk you guys through her full story, specifically as a teacher back in the day. So she grew up in Kansas. Hard work, kindness. Teachers are saints, really. If any of you have kids, summertime is a little bit tough because you're trying to do camps and you're trying to figure out everything. And if there's, like, in Texas, we have ice storms, and then when we have an ice storm, everything shuts down, right? So um, parents know that having your kids at home and then working and doing all those things is not easy. So you already know Miss Linda is amazing and she's sweet. And so she's been an elementary teacher for over 30 years. She met her husband Robert at a church potluck in her late 20s. And so now she lives in good old Allen, Texas. And she's got two kids, two children. They're all grown now, but their home was full of laughter and great things. And so over the years, it actually lived here in Collin County, or Allen, Texas. In her late 60s, she realized that she was getting really weak and tired. So she thought she was just getting older, because her mom used to tell her, getting old is not for wimps. And so she always thought that in her head. But the reality of it is that she was getting winded more and weaker. And even teaching her class, she was forced to early retire because she kept getting weaker. And so even cooking at home and doing things at home and chores would catch her breath. And so she decided, hey, I need to go see my PCP and my cardiologist and see what's going on. So the PCP and the cardiologist, they both coordinated and ordered home health services. So a nurse began to come out. We took care of her on home health, and the nurse would come out, monitor her vitals, make sure she's eating a heart healthy diet, coordinate with any changes in medications that she was taking, making sure she's weighing herself to see if there's any increase in weight, which is a common symptom of CHF if not managed. Physical therapy was coming out, doing some therapy, physical therapy, coordinating, getting her to do energy conservation strength techniques. So focusing on like pursed lip breathing, which is like through the lips and really smoothly to kind of keep her at ease. And a lot of this was great because it helped stabilize her for a while. And so she was on home health for a good amount of time with the regimen and kind of getting, stabilized and keeping her quality of life and doing treatments. But what began to happen is that over that period of time, specifically, her heart continued to get weaker and weaker and weaker. And then in the last 2 months, she found herself actually go back and forth to the hospital 3 times. And it was hard for her, even walking across the room, gasping for air. And then her last admission, which was the hardest for her and her husband and the kids, the cardiologist said, your ejection fraction, which is the amount of percentage that goes out of the heart into the surrounding areas of your body, her ejection fraction was way below normal, it's about 8%. And so with that, the doctor was like, there's not that many more treatments that we can do clinically, and maybe time for you to maybe consider a different option, maybe hospice care. And so, ooh, hearing that, they're like, hospice, what is that? What does that mean? And that's kind of where we're at right now. So if you're watching this for the first time, what we're doing is we do this weekly and we go through a hospice 101, basically a live, and we walk families through a scenario, which we just talked about Miss Linda and her specific scenario, which is a patient that we have, but we retell it and walk you all through that. And then now we're going to do the hospice 101, which is they are now getting the news and now they're like, hospice, okay, well, how do we start? Where do we start? And so where do we go from there? And that's really where we are now, is what is hospice? And so hospice is a benefit of Medicare or some private insurances, if they do have that within their underwriting, is a benefit that is available for those who are terminally ill or who have 6 months or less to live that qualify under specific guidance of diagnosis measures. And so this benefit is a big help for families when the time is right. And so a lot of times families are like, okay, hospice, does that mean they're going to die tomorrow? Does that mean they're going to die right away? And the reality of it is no. I mean, sometimes that does happen where, a loved one will pass away right away because they're that close. But a lot of times, if utilized appropriately, you can be on hospice for 6 months or even longer if there's qualifications. So what hospice focuses on is managing pain, symptoms, emotional support from a care team, and supporting the family and honoring patients and families' wishes at the end of life, which is huge. Where does hospice happen? It happens at home. It can happen at a group home. It can happen at an assisted living facility. It could happen at a nursing home. Hospice happens wherever you are. And so that is the beautiful thing. Some families want to stay at home and be at home. They've heard horror stories about nursing homes, do not want to go to a nursing home. They can be on hospice at home. And so when is hospice appropriate? It usually comes from a doctor. The doctor makes that established order to evaluate and treat. And then the hospice comes out and deems whether or not they qualify for hospice and if they meet that criteria for hospice care. So let's say we're talking now to Linda and her husband, and Linda's agreeing and saying, you know what, I've got my DNR in place, I've got my will in place. Let's just live the last days that I do have and enjoy the last days at home. And now she's interviewing a hospice. Maybe she goes on Google and says, okay, hospice near me in Allen, Texas, and then boop, finds a hospice. So now these are the things that as you, as a family, as a loved one, as a patient, these are the things that the best hospices will do, is they will walk you through what to expect prior to hospice. And so when we're talking about 3 core parts of hospice, there's a lot of aspects of hospice, but there are 3 things that are very kind of essential in the core to helping someone understand what hospice is way before they have any idea. And so we're going to talk about the care team, supplies, DME, and medications, the three core parts. So let's talk about the care team. Now, the care team is a team that's associated with your loved one once they qualify for hospice. So think of your main quarterback as your RN or your nurse who comes and does the admission, reviews everything with you of what's going on, what hospice is, what it isn't. And then you have a team. You have an aide who can come out. Now, the aide is not someone who's going to be there 24/7. The aide is basically under the guidance of the hospice nurse and creates a care plan. So let's say you need help with bathing. The aide can come out a couple times a week with hygiene and things like that. That's under the guidance of the nurse. Now, the aide's not going to be there to do all the house chores and clean up everything. The aide is specific to the diagnosis of hospice and to help keep you and your loved one comfortable underneath hospice care. Now, you also have a chaplain and a social worker. Some families need that emotional support through the chaplain, through the social worker. Now, it's your faith, your choice, but it's a benefit and it's a service that's available for families as well. The social worker's job is to also help with living wills if those things are not in place. In Linda's case, everything is in place, but maybe just making sure the funeral arrangements are in order, because a lot of that can be a lot, especially when you're not prepared. So having that support is a amazing help for families, and then the chaplain as well. And then you also have the hospice medical director. So the hospice doctor usually assumes the care for Miss Linda in this situation. So now Miss Linda had a PCP, had a cardiologist, and when it comes to the terminal diagnosis, then the hospice doctor will usually oversee that. A lot of times you can still pick if you want your doctor to be the attending, but what we've seen in most cases, in most situations, is that they defer the care to the hospice doctor. And then if needed, the hospice can relay information every so often, every 14 days at their IDT or their team meeting, to let the doctors know how Miss Linda is doing. And so it just depends, but that is usually done based off of the discussion with the nurse, with the family, and tailoring it towards what they want and what the disease entails for them. So that's the care team. In short, quick summary. Hospice medications are essential. So now when that nurse, that quarterback goes out and is doing the admission, the nurse will review what's covered and what's not covered under the medications. So now all the medications are also reconciled to review what needs to be done. And the beautiful thing about hospice is now it's all under one place. And so a lot of times what we see is that there's a lot of polypharmia. There's a lot of uh, coordination between several doctors. And so now it's all under one. And there's a great coordination that can be done now with the hospice coordinating all those medications, which is a big relief for families as well. DME. So now DME and supplies. Now these are all covered. The biggest thing to say is that under Medicare Part A, these are all covered 100%. So there's no cost, which is a big thing for families. Is now you can get supplies, you can get wipes, chucks, DME, hospital bed. And so the best hospice is what they do is on admission, where they tailor of what is needed for you and your family. And then as the disease continues to progress, they may layer on more things to help you and your family and guide you through that. And so where does Linda start? So the start is that interviewing the hospice, helping understand what is needed specifically when it comes to hospice services, and being informed and picking the best hospice that fits and tailors your needs. And so 4 simple things really to think about. Recognize that it may be time to start hospice. Get the doctor's order, which we talked about before, and then choose a hospice provider that is best for you, tailors towards your needs. And then the admission starts. And so now we talked about Linda. There's so many qualifications when it comes to hospice, but Linda specifically, you see all these emojis on there. You got the heart, the lungs, the brain, the ribbon for cancer, that old man with the little cane, stability or weakness, or kind of a whole bunch of different things, not eating, weight loss, and then the little blood is, of course, anemia, different types of blood diseases that all qualify for hospice. So now specifically, there's measures that have to be met. The hospice has to qualify. In Linda's case, hers is CHF, and those have to be there's specific measures that have to be met for her to qualify. We talked about insurance, and so Medicare Part A covers it 100%. If you're younger than 65, your insurance plan may have a benefit of hospice care. And in that situation, the best thing to do sometimes is to call your insurance carrier and see if there's hospices in network in your area that you can reach out to, because it's a little bit different with that than it is with Medicare Part A. And so now, 6 months later, Linda is on hospice. She has heart failure. She's not going back and forth to the hospital. Her daughter is now not the only one that's taking responsibility. You have an aide coming out several times to help with bathing. The nurse is closely monitoring how things are going. She's declining, and she's not doing that great, but she's able to live a good quality life and do a good job of loving her life with her grandkids to the best of her ability. And she's surrounded with family and able to live her last days with peace and dignity. So that in a nutshell is Linda's story. And so every story is a little bit different. And what we look at a lot of times is so many continuum of care when it comes to care at home. Linda went through home health. Let's say she did need some help at home. She would have to pay for personal care, or if she had a long-term care insurance. Now, palliative care would be another measure. It's not a specific program that is underneath and covered by Medicare yet, hopefully. But it is an approach to care that she could have get if she wanted to continue to do aggressive treatment. But then the last part, which we talked about, was hospice, which she decided to do, which is a great benefit and a great choice for her. So in a nutshell, the biggest things that we like to say is when you're looking at understanding hospice, choose interview hospice. The best hospices will guide you and walk you through these steps. And now it doesn't negate that it still may be a turbulent, a tough time. Hospice is not going to cure anything. It's not going to relieve everything. It's not going to help with everything, but it is there to be a guide and to help you through a very difficult time. I always like to say this, just like when you're traveling from here to Chicago or to Kansas, in Linda's sake, the pilot may say there's going to be turbulence. Now, the turbulence is still going to be scary, it's still going to be there, but knowing that you have someone that at least navigate you through that, that's what hospice is for, and that's what it's meant to be. So I hope to help you guys. We got a couple seconds here to answer a few questions. I think JT may be in the back ready to answer a few or to shoot over some questions. What's up, JT?
Hey, what's up, Charles? Thanks for the presentation. This is very similar to the conversations that we have with families, when we go into the home or the hospital or the rehab or wherever kind of these happen. So
Yeah.
It's cool to see it kind of online as well.
Yeah.
One question today, we learned last week, there's a statistic out there that says families need to hear hospice 3 times before they feel ready to either talk about it and consider it. I'd agree with that. That's pretty accurate. But when is it too early to ask a doctor or a home health team if there is home health there? Like, when is the right time to ask? You said frequent hospitalizations. What are some of the signs you see when it's like a appropriate time to ask about hospice?
Yeah, great question. I think a lot of times there are the big triggers, like we talked about, is the frequent hospitalizations, and then your loved one's wishes and what they're telling you. Now, if your loved one's saying, "Hey, I'm good. Let's go to the hospital. Let's figure this out. Let's get the treatment going. Let's do everything." That's not the time to bring up hospice, right? But if they're saying, I'm tired, I can't keep doing this anymore, I'm weak, I've done the best that I can, I just want to be home, right? There's so many cues that really paint the picture, and I think those are the biggest triggers: the frequent hospitalizations and what your loved one is saying, and honoring their wishes, because a lot of times that's the hardest part. Those are the things that we see. Is that sometimes the best time.
Yeah, and if you're watching this and you don't know what your parents' wishes are, talk to them.
We were just, me and JT were talking like, I had to talk to my parents. Say, "Hey, mom, dad, let's sit down, let's talk. What do you want?" So that way, as adult kids in the sandwich generation, like, we're not trying to figure out what to do while we're taking care of our kids, and then it's good to have those early conversations. So.
Sure. Well, thanks for your time. I appreciate it.
Yeah,
awesome. Thank you all for hopping on today.
Yeah, thank you, guys. It's good to see you guys. We'll be on again next week, Tuesday. But if you have any questions, feel free to go to hospice.charlin.org and then give us a text. You can also text that number 972-778-8038. We're in the Dallas-Fort Worth Metroplex. That's our area of coverage. So feel free, if you have any questions, reach out to us. We're here for you. So, all right, sweet. God bless, guys.